today. So I wanted to first of all acknowledge this note that we got from Senator Bro's family. Senator Bro served us here in the state of Indiana for a number of years, and her family has sent a note to the Commission on Aging, gratefully acknowledging and thanking you for your kind expression of sympathy. We miss Senator Bro. Okay, before we can do business, we need to know if we have a forum. So let me do that, and then we will welcome our new member this morning who's here. So let me do roll call first, and then we'll go to that. Becky Onspa, are you on?
I am. Good morning.
Good morning, Becky. Bob Bischoff. I am here. James Gone. James, are you on line? Katie, I know you're coming. I'm going to count you here.
I'm here, Joanne, on the phone.
Okay, thank you. Deb,
Thank you.
You're welcome. Deb, you are here from not South Bend, oh boy, I'm sorry, Fort Wayne. That's okay. Jennifer Lance.
Good morning.
Dan, are you on the phone? Dan Munster on the line on virtually? Yeah. Judith Shun, are you on today?
I am here.
Great, Judith. I'm glad you didn't blow away up there, but it sounds like you had quite a storm.
We did.
Okay. Jake Sype. Jake, are you on this morning?
Good morning. Yes, I'm here.
Hi, Jake. Welcome. Margaret Smith. Megan Springer. Kelly Tungate. Kelly, are you able to get on yet today? Kelly maybe she's at a meeting. She may be. That's okay. We do not have a forum, but a forum, not forum, a quorum. So I'm going to simply file the minutes and we'll deal with them the next week. Can't do anything official with that. Okay. Well, I want to also welcome our new member today. Steve McCaffrey has been appointed to the Indiana Commission on Aging. We are grateful that we have a voice now that is specifically focused on older adults in Indiana who are struggling with some mental health issues. So I want to welcome you, Steve, and ask you to introduce yourself to the commission.
Thank you, Dr. Burke. Steve McCaffrey. I am the president and CEO of Mental Health America of Indiana. I'm excited to be here. I have been involved in mental health and aging issues for much of my career and served on the Choice Board years and years ago and then rolled off. So I'm excited about the new chapter here, and if there's anything I can do to be helpful, I'm happy to do that.
Wonderful. We have some advisory committees, and I'm sure I'll be talking with you a little bit about joining some of them. It's a way that we get a little broader voice across Indiana, and we certainly need your voice in some of that. So thank you so much. And Aaron, you're going to give us an update on where we are with recruitment for the Commission on Aging.
Yes, thank you, Dr. Burke, and good morning, everyone. In May, we discussed the new positions and vacancies on the commission related to House Enrolled Act 1067, which is now part of Indiana Code. At that time, we had 5 vacancies. Since then, one new member has been appointed, Steve, so welcome. We have applications. And Jake, yes. Thank you. The positions that are pending with the governor's office are a direct provider of or service worker employed to provide services provided through the Division of Aging. And then we also have 2 at-large type vacancies, which there are applications being reviewed at the governor's office for those. So we are still looking for an applicant who is a recipient or caregiver of a recipient of services provided through the Division of Aging. It's really important and would be beneficial to have the consumer voice on the commission. So if anyone knows anyone who may be interested in serving in this capacity, feel free to pass along my information, or you can provide their information to me and I will reach out and send them the application forms. There are requirements as far as balance of political parties within the commission membership. We're not allowed to have more than 8 members of the same political party. We're also not supposed to have more than 2 members from the same county. So currently, we would not be able to forward any applicants from Allen County. But otherwise, please send anyone that you think might be interested. And I'm not sure with the governor's office what kind of time frame we would be looking at for appointments. So hopefully by the next meeting, I'll have some news. Right, thanks.
I have a request. We have a person that's trying to get on the link to the meeting, the public link, is having difficulty. Could somebody please send me that link from the Division of Aging, and I'll forward it on to this person. Thank you.
You trying to watch the YouTube or the Zoom? Okay.
Now that I can't tell you, just the link's not working, that's what she said. Okay. Well, we have lots happening in Indiana right now. How about that? That's the best way I can put it. Some things are going well, some things are challenging. How about that? That's the way I know how to say it. So, okay. Well, we have with us today Kathleen Dillinger's coming from the she's Director of Quality Improvement for the Office of Medicaid Planning and Policy, or Policy Planning, and going to give us an update on pathways and pathways pays for outcomes. So Kathleen, thank you so much.
Thank you. Oops, sorry. Let me go ahead and share my screen here. All right, good morning. My name is Kathleen Dillinger, and I am the Director of Quality Improvement in the Clinical Operations Department at OMPP. Thank you for having me here today to discuss the Indiana Pathways for Aging Pay for Outcomes program. Today, I will be providing an overview. Let's see. We're not moving on there. Let me try to reshare because it wasn't advancing. I apologize for the delay. Okay. Today I will be providing an overview of the Indiana Pathways for Aging outcome program. I will be discussing the 3 main quality goals for the Pathways program and inform about the pay for outcomes measures that are in the Indiana Pathways for Aging program and provide an overview of the next steps. The Pay for Outcomes program is a way to support the three main quality goals established for the Indiana Pathways for Aging program. The intent of the program is to ensure that members' individual needs are being addressed, there is access to care, and the goal that optimal health can be achieved. The goals and measures outlined in the Pay for Outcomes program were purposely developed so that they could be achieved and improve health outcomes. They were also designed to align this with the state's quality strategy plan. The state's quality strategy plan outlines the goals and objectives for ensuring Hoosiers reach their ultimate well-being, including emotional well-being. The Pay for Outcomes program occurs over a fixed period of time, and the success of the program is monitored throughout and fully evaluated upon completion. There are three overarching quality goals that have been identified for the Indiana Pathways for Aging program. The first goal ensures that members are supported in the services that they receive and that individual needs, including those related to social determinants of health, are met. The second goal focuses on ensuring that members get care at the right time and in the right setting. And the final goal ensures that members' health and care needs are met to improve the quality of life. By aligning goals, the three quality goals, to the Pay for Outcomes program, it ensures that members' needs are addressed, which leads to members obtaining optimal health. The Pay for Outcome measures that are listed here are focusing on ensuring that members' individual needs are being met in a timely manner and to the member satisfaction. These goals are monitored throughout the program so that we can ensure that targets are being met and that we are on track for the outcome that we would like to see. So the measurement period for the Pay for Outcomes program begins July 1st and will end on June 30th, 2025. I'm sorry, there's a typo there. The Pay for Outcomes measures are monitored throughout length of the program, and the evaluation will occur at the end of the measurement period. And I will be happy to take any questions at this time.
So where are you drawing your numbers from? So for your measurements, where are you pulling that from, databases or?
Yes, so we receive reports from the managed care entities,
Mhm.
and we use additional data sources for those particular metrics that we have identified for the Pay for Outcomes program.
And what would those additional data sources be?
So we have internal data sources that we utilize, such as claims. We also have clinical reviews that are being conducted by our care programs team, and the data that they gather from those reviews are also incorporated into the metrics.
Okay, and then I just have a question. So will this data also include like prior authorization and then denials on prior authorization, and then with a follow-up, or were there any negative outcomes from those denials of prior authorization?
Not for these particular Pay for Outcome measures, but we do monitor prior authorizations as part of our normal reporting process.
So if the goal of this program is to cut costs and increase quality, I would think it'd be really important to monitor the denials from prior authorizations and any negative outcomes. And if there gets to be a time that's appropriate, I'll share a specific concern that I have regarding prior authorization requests and potential for, honestly, being penny wise but pound foolish with some of this program.
Yes.
All
I
right,
understand.
thank you.
Thank you.
Well, I think we just need to talk about, if you've got something to raise, you can raise it now.
Well, I don't want to interrupt your presentation.
Well, I don't
Yeah,
know.
I'm,
This the.
yeah, this is the question and answer part of
Oh,
the
okay.
presentation.
Excellent. So, so the community that I work at, we have been contacted, today's 18th, we've been contacted by one NCE so far for care coordination, case management, so only one of the three. And it only represents 15 of our residents, which we have over 70 some residents that will be a part of this program. And yet we have a resident that has a known history of internal tunneling wounds. And this person's lived with us for 8 years. So over time, you learn like signs and symptoms, right?
Right,
You
yeah.
know your residents, if you truly provide resident-centered care, you know those signs that your residents are putting off, that something's starting to go off track. Let's be proactive. Let's get this before it's a problem. So we had wanted a CT scan to see if we had the starting of some internal tunneling for this person going on. And we were told we had to prior authorize that. And the frustrating things about wounds is they can develop and get worse very quickly.
Yes.
And this was on July 3rd, so 3 days into this, we are already given a denial. And the hospital's like, yeah, we're gonna cancel that. So it's hours before a holiday weekend. I serve, and I'm just gonna tell you, I get very passionate about my people.
I understand.
I serve a population that is predominantly mentally ill, and they cannot advocate for themselves. And I depend on my team to advocate for them. And I'm not thrilled with the start of this program. And I'm not thrilled with the numbers that came out about this program, as far as we've got this wait list and we're gonna put 800 people a month. Well, do the math. You got enough slots to do 881 to fill the slots. So is the goal then not to fill the slots? I know it's early and I'm gonna try to be patient. All I can say is, don't mess with my people. Because they don't have anybody else to advocate. And I'm frustrated.
Amen.
So I didn't mean to get emotional. I
No.
prayed the whole way down here that I wouldn't say something out of line. But I am frustrated already.
That's definitely helpful to hear, what is going on so that we can look into any, any inconsistencies or
So when I say pound line penny foolish, like luckily he didn't have, so far has not had a negative outcome.
Mhm.
But you have a price of a CAT scan to either verify that we got tunneling started or not, versus this tunneling happening, and now he's in the ER. Now he's having some emergency procedures done and potentially going in ICU because of it. Sepsis is a big issue. So I don't want to just paint the most negative picture, but I believe in hope, but I don't run a business based on hope, right? I run it based on facts. I run it based on a plan. And I hoped all weekend long that he was going to be okay. And I'm thankful that he is, but this is going to age me significantly to care for the people that I care for on hope. I'm just sharing that.
I would be happy to talk with you offline because part of the area that I am in is quality improvement, and clinical quality improvement, which involves quality of care. And it sounds like there's a quality of care issue, so I'll be happy to talk with you offline to get more information so that we can follow up.
Thank you.
Well, thank you to both of you and for discussing this. And Steve, please.
I don't want to cause trouble on my first day, but
We're looking for how to work together. So,
is there a possibility of, and I don't know if the commission would be interested in the data or not, but
would you bring your mic closer?
I'm sorry.
Everybody. Thank you.
doing a comparison of barriers like PA for fee for service and then each of the MCOs, and then monitor how many clients or patients are affected by each MCO? Is that possible?
Yes, that is possible.
Because I know on the Mental Health Quality Advisory Committee, which is meeting now, unfortunately, they do that with drugs. And the committee can look at that and see trends and outliers and trouble and then try to fix it. And so I just thought that out as a possibility.
Yes, that is a possibility, and I will take that back.
Thanks.
Hi, this is Judy. Can you hear me?
Yes.
Okay. I was in the advisory committee with NICA, which is co-action called now, and on Monday, and they are saying they are having major issues with getting approvals and getting confirmation on stuff, finding somebody to talk to. They getting passed down to different people all over the place. They really are very upset right now.
Noted.
Katie. Katie, do you have something you want to add? Maybe in transit. Okay.
Looked like she was trying to talk.
She's trying to talk.
It looked like she was, but she stopped.
Hello?
Yes, Katie.
Yes, I'm so sorry. I was disconnected momentarily. Did you ask? I was raising my hand. Is this an appropriate time for a question?
Sure, go ahead.
Okay, I hope I didn't interrupt Judith.
No, it's fine. Go ahead. It's your turn.
Okay. I was wondering if the speaker could share a little bit more about the items. I know obviously it's probably a long list, but the items that will be used for evaluation related to quality of life. Maybe give us a few examples and the items that will be used in your evaluation on the financial side of the change. Maybe 3 or 4 examples in each category to just help us understand what will be evaluated. Thank you so much.
Yes, I cannot speak on the financial part. I am in the quality section, so I will have to defer that question to the Indiana Pathways program team. But I can tell you a little bit of what we have, and this is also outlined in the quality strategy plan, which is located on our FSSA website. So there is a quality strategy plan that outlines all the metrics that will be utilized to evaluate the program. It also includes the performance improvement plans that the MCEs have, that is outlined there as well. So we have several things that we are utilizing, and we're taking a stepped approach to evaluation. So we have some metrics that we are utilizing, which are early indicators. Those would be metrics that you probably are familiar with, preventative health screenings, immunizations, et cetera. And then we have metrics, a next level of metrics, which are our performance metrics. And those metrics are the ones that we are going to be utilizing to evaluate the program. And again, these are outlined in the quality strategy plan. And those metrics are more focused on health outcomes. So it would be, an example would be, for example, diabetic, and making sure that the diabetic population is within control for their blood sugar levels. That is one example. Another example that we have in regards to mental health is ensuring that members are being followed up if they happen to have an inpatient stay or if they have an ER visit related to mental health. We are ensuring we have metrics in place to ensure that members are being followed, and we'll be monitoring those as well. So those are just a few examples of metrics that we'll be using as a performance evaluation. We also have some watch metrics, and what these metrics are metrics that may be new. Either CMS came up with them or NCQA, which is the National Committee for Quality Assurance, and they're the ones that do the accreditation for health plans. So sometimes they have new measures that come out or that there's significant changes to those measures. So we have them as kind of a watch metric to get enough data before we're actually going to be utilizing them to as a performance measure or as an early indicator measure, depending on what it is. Did you want any additional examples?
Katie,
No, I think you're, yeah. Go ahead.
I don't know like who the right person
I
is.
Katie, you're breaking up. We can't hear you.
Okay. I wanted to say thank you for the explanation, and I'm sorry, I'm gonna log on to my computer right now, so hopefully that will be easier. But I want to say thank you for the explanation, and I'll take a look at the document referenced online as well. Appreciate the explanation.
Okay, thank you, Katie.
So, and again, whoever's most correct person to answer this, just, so how are we going to know of the people on pathways that they've been contacted by a care coordinator or a case manager? Because, I mean, it's easy for me to monitor our folks. So I've had 15 out of 75 that have had some contact 18 days into this. But what about these folks that are home? How are we going to know if they've been contacted by someone? And since they're probably not used to having that level of case coordination and care oversight, they might not even be aware, like they're supposed to get in, you know, somebody's supposed to get in touch with them. So how do we monitor that? Because I think that's also, well, honestly, it's part of the RFP, right? They have certain requirements that they have to meet. I know that we just rolled this out. We're clearly not meeting them right now, so I'll be patient for another 18 days. Just kidding. I'll try to be patient for as long as it takes, but, so yeah, whoever's the right person.
So yeah, that would be more a question for our Pathways program team.
Sir, oh, thank you.
And
Please,
introduce
somebody.
yourself. I know who
Please
you
speak
are.
up, I think.
Thank you. Thanks, Kathleen.
Yeah, Kathleen's doing a great job, but as she mentioned, she's the director of quality improvement. So her focus is in specific areas. My name's Cora Steinmetz and I'm the director of Medicaid for the state. So thanks for recognizing me and allowing me to come up and help it pitch in on some of these questions. So I'll address this question first, and then if I could just speak to a couple other things that I heard, and I apologize, I came from a different meeting, so missed the beginning of the conversation. But as far as care coordination monitoring, there is extensive reporting that's required from the MCEs that includes both care coordination and service coordination, because of course our waiver members are also assigned a service coordinator. And the MCEs have to report to us on how many attempts that they've made to contact, the face-to-face visits that are required around service coordination. And that information is reported to us on an ongoing basis. Right now, that's weekly reports that we're receiving. So we have transparency today into how many of those care coordination visits or outreaches have already occurred from each of the MCEs. To your point, obviously, they've not contacted all of the 120,000 individuals who are in the Pathways program yet. That's on a rolling basis, and there's some specific expectations we have around those regards. With that said, if an individual is in need of getting in touch with their care coordinator before the care coordinator has made that proactive outreach, we have specific phone numbers that can be contacted through the MCEs. And I heard another question online about there's questions about authorizations or not being able to contact anyone. I'd love to share, we have sort of a one-page document that's sort of a member-facing resource set of phone numbers, emails, et cetera, as well as a provider-facing one that has additional information about who to call if you're struggling with the MCE contracting pieces of things, who to call if you're struggling with authorizations, and specifically sort of the care coordination piece. So I've met with all 3 plan presidents this week, and they've had some really encouraging stories about those care coordination outreaches that have taken place. So they're really ramping up in that regard, and I would expect many more calls and visits in the next weeks and months to come.
So I'm going to, I always want to be respectful. I really do. As a provider, I spent over 2 hours, both on the phone and with the headset, literally emailing all these little provider people. This is for one vendor, okay? And I cannot tell you how frustrating that whole experience was. So I'm on the phone because I'm of the generation that appreciates personal contact. And so I'm trying to talk to somebody, oh no, you need to get on the website. So I said, well, literally, I'm sitting here on this website while I'm speaking to you. And I've been bounced around 6 different times. And now you're sending me back to contracting. Been there, done that. And it was the most frustrating thing. You know, it's 2 hours of my life I'll never get back. And that's one MCE. And the other thing I'm going to say is if you simply rely on your MCEs to give you their feedback from their side of the story, you're going to get a very rosy vision of how this thing is going. I think it's incredibly important because this program was supposed to be for the citizens of Indiana and not for the MCEs. I think it's very important that we actually contact the citizens of Indiana who are on this program to actually hear what their experience is. Because if they're telling you that this stuff is going great and it's going rosy, I'm on calls with providers that might tell you a different story. And I really am saying that respectfully. I don't mean to be contentious, really.
Thank you for that. So great segue, I think, into some of the auditing that we do of the MCEs. We don't just rely on the information that they provide. We have across the entire board. In fact, Kim, do we have people on site today at MCEs doing? We did all 3 MCEs. Okay, so we are on site at the MCEs, sitting side by side, listening to those phone calls, talking with them about their experiences in all sorts of different things, including care coordination, because you're exactly right. That's our job as the oversight entity and as the individual agency with the contractual relationship overseeing the MCEs. We obviously receive data from them, but we do our own independent audits of their work from an oversight perspective. Additionally, I'm sorry, you mentioned one other thing that I wanted to address about member surveys. We do member surveys as well, because we completely agree with you that we need to hear from the members or the citizens about their experience with the MCEs. The other thing that I want to mention that is an opportunity to reach out if you feel that the MCE is not addressing issues in an appropriate manner is that we have an independent member support services vendor, which operates similarly to an ombudsman. It's not the long-term care ombudsman. It's separate from that, but it is an ombudsman that sends reports directly to the state and will help sort of facilitate any sort of issue resolution with the MCEs. You can obviously come to the state with those issues, but we feel it's important, and there's certain CMS requirements as well about having that independent entity that can kind of provide that level of oversight.
Can I have that phone number, please?
Sure, and it's on the resource page that I'm happy to share for this group.
It's on the top of the website. If you go to the Indiana website, it's right there.
Okay.
Yes, let's introduce.
yourself.
Yeah.
please.
I apologize. My name is Kimberly Bremer. I am the director of Pathways. And so I came down to help with some of that. And I do want to, I got cut off when I was walking down, but you are concerned about reaching out. All members have been reached out prior to go live by the MCE if they were in current waiver services or getting home and community-based services. There was a touch base and we actually audit to double check. They left messages and had to go back through, and it was 3.5 weeks of full contact to the members so that they had that outreach. Whether that was effective or not, I cannot say, but I do know that there was a full outreach and we did do audits and spot checks and listened into those calls. We understand there is some transition with the call centers. The call center volume was a lot larger than any of the MCEs anticipated. So they brought in other call center people that weren't as trained as well as should have been. And they're continuing doing training as well. And we're continually giving them talking points and ensuring that those are. So if you had to experience the first week compared to today, you'll see a totally different experience. So it is a little bit of a learning curve as it's been developed just because of the quantity of calls. We encourage all providers. I talk to every one of the associations between myself and my team almost daily. So we get a lot of the provider feedback. We ask them to send all concerns directly, anything from billing to authorization or other concerns, to the Indiana Pathways at fssa.in.gov email box. And we're triaging those back and getting results back to every one of the providers on there. And then, as we said, the MSS number is available. And we're encouraging all members, if they have attempted to call the MC and feel like they're not getting what they need or answers, to call the MSS line so that we can monitor that and support the member to make sure that it is transitioned, because we know this is a vulnerable population. So we're working through. We're not saying we are aware of the same frustrations you are, but we're not seeing any systematic things. We're seeing a lot of them more isolated situations, and we're trying to plug all of those and rectify it as they come up. We were pretty proactive, so that's why we're really excessively engaging with the providers and the provider associations. I was with IPHCA earlier this week. I talked to the Home Care Association this morning before I came in. I know Holly, my boss, was talking to the Nursing Home Association this morning as well. So we are seeing those and trying to address every issue as they come up. We did publish a continuity of care bulletin, and we're reinforcing that. Anybody who had authorizations in June will continue to get their same services throughout the 90-day period. So all authorizations are being upheld. So if they had a prior authorization, we are insisting that providers provide the service and the MC will pay for those services.
That's great. Thank you, Kim. And I also just want to mention that to Kim's point, this is not a flawless rollout. I'm not aware of any state or any program across all the agencies that has a perfect rollout, but we have heard a lot of success stories early on. And so I would be remiss if I didn't mention that we've heard really good feedback, as well as the feedback of things that need to improve. So just want to mention that some really meaningful success stories at the member level, at the Medicaid member level, because at the end of the day, that's where our primary focus is.
Can you speak to,
No, go ahead.
you said you were getting data each week, and I know some of the ratio requirements for service coordination and care coordinator, are they meeting those ratios? Are we seeing that level of staffing, or is it?
Yes, so the MCEs staffed up very quickly in the service coordination space, and have moved staff around in order to be able to facilitate to meet those service and care coordination ratio requirements. Thanks for the question.
Cora, I was just gonna say, and I don't know if you were here when I said this earlier, but I've been involved in other rollouts and served on other committees. And one of the things that some of the committees do is have like a standing order on the agenda, and they allow the MCEs to do a coordinated presentation.
Yeah.
And I think and I'm just speaking for myself, but I think it would help you frankly, because but it also helps with transparency and allows people to talk to the MCEs directly. And at least my experience before was we spent a lot of time pointing fingers in a circle. But if the commission could talk directly to the MCEs, they're very receptive and they want to fix it.
That's right.
And so just throwing that out as an idea.
I'd love to, if Dr. Burke feels comfortable with that. I think that's a great suggestion, Steve. Thank you. Yep, we've done that with to Mr. McCaffrey's point, we've done that with the MAC, the Medicaid Advisory Committee, and it's gone really well. And the MCEs are happy and eager to share their stories with you all.
How about the commissioners or?
Yeah, it'd be great.
Okay, we are requesting them. Yeah.
Okay, thank you so much.
Just,
I'm sorry.
last question, I'm sorry. So I know that there have been parts of the state, there have been healthcare systems that have dropped some Medicare Advantage folks, and some of those folks that have been dropped also provide Medicaid managed care. Are there any concerns that there might be some issues for those folks, for those healthcare systems that have dropped that provider?
Yeah, thanks for that question, because it definitely is something that we are monitoring really closely. I will just say personally, it is challenging that in these contracting, particularly with the large hospital systems and the insurance companies, it's challenging that at times those are packaged into a single contract negotiation, because Medicare Advantage operates very differently than managed Medicaid. If I could speak somewhat freely, we oversee the managed Medicaid programs very differently than CMS oversees Medicare Advantage. And so the reality is, though, that the hospitals and the insurance companies are negotiating at times at their entity level, of course. And so the Medicaid managed care programs can get swept up into those negotiations around Medicare Advantage. And sort of typically it's around rate discussions.
Right.
I am not concerned about network adequacy today, though, as a result of that. For the most part, many of those sort of deals that have fallen through later come back together and result in the contract coming forward on both Medicare Advantage and managed Medicaid. The other big difference here is that we have an open network for the first couple of years of this program. So the in-network and out-of-network concerns for pathways are not the same as they are for sort of someone who has traditional Medicare Advantage or is in a different program, because their provider, even if they are in network, can still bill that Medicaid program and receive reimbursement.
Okay, well, that's good to know.
I have, before you leave, Cora.
Sure.
Because I think this goes to you and not to Leslie.
I'm stealing Leslie's thunder here, so
Well,
sorry, Leslie.
Probably not on this. The Commission on Aging works in an advisory capacity here with the Division of Aging. Now our people have moved over more into your area.
Sure.
My question is related to wait lists. What are we really looking at here? We have a backlog. How big is the backlog? How does this look for the coming year? We have a growing number of older Hoosiers who are going to be requiring services, needing them. What does that look like? Because their quality of life doesn't necessarily get better on wait lists.
And I might ask Leslie to come help on this. The one thing I do want to note while Leslie's coming up, because she's probably got the information in front of her, whereas I would not get the numbers completely right off the top of my head and don't have my right phone in front of me to quickly check my email. There is one thing that I think is confusing for the general public, for our staff, and just the healthcare ecosystem as a whole. There is the Pathways program and there is the Pathways waiver. And Dr. Burke, I know you know this, but just for the benefit of the larger group, if I might, there are about 120,000 people on the Pathways program, and roughly 30,000 are waiver eligible and are on the Pathways waiver. The wait list impacts only the waiver. It is not a wait list for the Pathways program as a whole. And I just have been trying to say that in every opportunity that I get, because I don't want anyone to think that they cannot access services under the Pathways program that they don't have a care coordinator, because they do, it's those waiver services. Certainly your point about waiting for services and the quality of life concerns are very valid, but it is for that narrower population.
Hi, Leslie Huckleberry, Director for the Division of Aging.
Thanks
Can you repeat your question on the wait list, just to make sure I answer the question? I can go ahead and give kind of the wait list update as well, if that's what would probably be helpful, I guess. So we did back in April announce that we were going to have to implement a wait list for the age and disabled waiver. That waiver, as hopefully everybody knows, has transitioned to 2 separate waivers as of July 1st, the Pathways waiver and the Health and Wellness waiver. As we entered a new waiver year on July 1st, we have had slots become available for both waivers. But we obviously had a wait list that built up over those few months. So we took a look at the number of available slots, the number of individuals on the wait list, and our capacity from a process standpoint on how many folks we feel like we can reasonably process per month through that eligibility process, and have started inviting folks off of the wait list and onto both the Pathways and Health and Wellness waivers. The number we are starting with is 925 individuals per month. So that is 800 individuals for Pathways and 125 individuals for Health and Wellness. We've got around 12 or 13,000 people on the wait list today. So we know that obviously there are lots of folks that are very, very anxious about getting access to services. We are very anxious about getting folks connected to services as quickly as we can. We also wanted to be transparent and realistic on the number of individuals that we could process per month through the eligibility process. If we invite 13,000 people onto the waiver in 1 month, there is no way we're processing any of those folks, and that would still take the months-long process that this is going to take going through this cadence of invites. So a lot of this was our effort to be transparent and help folks understand that it will take time to work through this number. They have to go through face-to-face assessment with the AAAs. So we're monitoring the AAAs and their ability to kind of process those, and working closely with them to make sure that they're able to process the folks that we're inviting off the wait list. Our internal staff, there are processes for approvals, matching data between systems, all of those things that we have to do as well. So we're starting with 925. Everyone on the wait list has gone through some level of assessment already. So our hope is that if you're on the wait list, you need the services, you want the services, you're going to be eligible for the services. But there are folks that will still need to get through their Medicaid financial eligibility process as well. So
is that slow too?
that takes time. It depends on everybody's individual circumstances, right? So that depends on the type of resources that you have and income. If you have to go through an interview process with DFR, the Division of Family Resources in charge of financial eligibility. Some folks may have pursued Medicaid eligibility while they were on the wait list. Others either waited or need the special income limit that's only eligible if you're joining the waiver.
Are we not having people available to process them, or is it for that's what I'm asking. We have capacity on the site, on the government side, to process them in Medicaid?
So we do, but it takes time. So it's not. Yeah, so it is a process. It takes time, and ultimately it does require people to do the work, right? And so there is, like I said, internal to FSSA. It also depends on the individual being able to collect documents and information and get that back to us. Their caregivers being able to do that as well. So I mean, it's in an ideal world, it would work smoothly, it would work quickly for everybody, but we know that's just not the reality of the process. So we're starting with the number that we landed on. We will monitor it. If we can increase it, we will. If we see that, hey, this is causing bottlenecking, we'll address that as well as we can. But that's what we're trying to do, right? I mean, we want to get people connected to services as quickly as we can. But we've got to make sure that we can actually process it and get them through there.
Okay, now this is a question, and it just might be me being naive or uninformed because I don't work in it. But some of these people that are on the wait list, their health is going to deteriorate as they sit on the wait list. What is happening between the wait list and the 120,000 already on the Pathways program? These people move in Pathways then.
If they are eligible for Medicaid, yes, they can still access Pathways.
do they, how do I say this except to ask it? Do they know that?
I would hope so. We're doing everything we can to provide that information. We're working with the AAAs and their ADRC function to do what we can to make sure we're sharing information for folks. So if they come in saying, hey, I need services, and maybe they're not qualifying for the waiver because they have to be put on the wait list, we're still connecting them and working and hoping to get them connected so they can get Pathways eligibility for the Pathways program, even if they're not ready for the Pathways waiver program yet. Which happens every day anyways, right? I mean, even without the wait list, you may have someone that comes in, doesn't qualify for the waiver, but may still qualify for Medicaid.
Who's helping these people know? Because I know some people struggle. And I try to talk to them, they just can't understand it. It's just too complicated for them. Who's working with them to understand that if the situation's deteriorating as they're on the wait list, that they can move forward with that?
So we would encourage people to contact their AAAs as their ADRC function to share with them what their options are, what programs they might be eligible for. That's really sort of the front door for a lot of our programs.
And did I understand you, even if they're on the overarching Pathways program, they still have a care coordinator or care manager, so they would probably help navigate that?
That's right.
Yes,
Yeah.
if they're on Pathways, then yes, they should be contacting their MCE and their care coordinator.
Yeah, but if they're on a wait list for a waiver.
Right, so whether they're on a wait list for the Pathways waiver, they still should have a Pathways care coordinator. Am I wrong?
If they are Medicaid eligible,
Right.
right, they have to go through that financial eligibility to be enrolled in Medicaid, like any of our
Right.
programs. But if they've done that, they're assigned to, they select an MCE, and then they have an assigned care coordinator.
Pathways is their Medicaid.
So what
The
you're
waiver
saying
that's
then is, while they might be waiting on that Pathway waiver program, there's still other Pathway programs that are available to assist them with their health needs.
That's what I don't think is understood.
I mean, it could be, since it took us 10 minutes to figure it out
I
here.
mean, and they, they're bouncing back and forth. They say, well, maybe we can get on choice. Well, maybe we'll, they're not understanding. And these are people that it seems to have taken a very long time to get qualified for Medicaid. I'm not throwing knives at anybody. I'm just trying to, I usually come and try to ask questions from the general public because they are confused.
Yeah, so a kind of a follow-up to that is, so you have someone that needs, because we're in this transition period, right? So there was a person that got referred to my community. They were Medicaid pending. And I'm like, waivers are already full. They've already filled them for 24, 25. We're not taking this person. That'd be the first Medicaid pending I've turned down because of Medicaid pending status. Are you all concerned at all that you're gonna have nursing home level or assisted living level of care folks that are gonna be on that wait list? And then what do we do with that? I mean, because there probably are some other folks that are Medicaid pending in a nursing home right now. And nursing homes will only take no payment on someone for so long, and then they're gonna have to come up with a different plan. And my other worry is, I worry a lot. So my other worry is when they're in the hospital and they determine they need a nursing home level of care because maybe a onset stroke or something, and now they're paralyzed on one side, they can't function in their own home, something, don't have supports, stuff like that. And again, there's no waivers available. What are we doing with?
Yeah, so a couple things on that. So one, yes, it is challenging, right? I mean, I think again, our goal is always to connect people with the most appropriate services available to them. We're in a tough spot right now, but for folks in nursing facilities and folks in hospitals, those are priority categories under the waiver. So if you are in a nursing facility for a certain period of time, if you've been hospitalized for a certain period of time, you do move toward the top, I would say, of the wait list. Now we have to still look at other folks that are in the priority category, right? But if you're in the priority category, then you move toward the top of the wait list. So we do, under the waiver requirements, try to triage as best we can with that. But it is something we'll continue to monitor because to your point, I mean, they'll need help somehow, right? And so if it's not through the waiver, then you're looking at state plan, traditional Medicaid services, which is nursing facility or home health aid services, home health care services, things like that. So it is something we're monitoring as we kind of move through this period.
Yeah, it makes me wonder, I mean, are we really going to have, we're trying to cut back the number of people in nursing homes with, as a cost containment strategy, but boy, if we don't have any way to help them out at home, they're going to be in the nursing home, and I'm trying to make sense of this in my head, and it's hard to explain it to people because they don't understand the program anyway. That's not blaming you, I'm just saying they don't. And it's just a hard thing. Do we see this working itself out in a year or two? That was kind of where I am. Or are we going to be so backlogged that we're going to?
I think,
Well,
no,
backlogged
it's
and
gonna be like
how we get
that.
it.
Was that 12,000 wait list, that was created just from April to now?
So a chunk of that were also individuals that were moving through the process when we had to put in the wait list in April. So it's not just from April to July 1. Yeah. And
Is
it's all
that
wait
volume
lists.
at 800 or 900 a month going forward, we're never coming out of that? Like, that's only gonna.
I think that we will, right? And
Right.
so it will take time. I think that we will get there. I will say on the health and wellness, so for the 59 and under, the number on the wait list exceeds the number of available slots for this waiver year. So that one will remain on a wait list. Pathways, we do have additional capacity above what the wait list is at today. So like I said, I mean, we're doing what we can to move through this list as quickly and methodically as possible. And so our goal certainly is to get through everybody on the wait list and get back to a point where people can access a slot available to them, and we don't have that queue, but it will take time. And so we're going to continue to monitor over the year. We have a biennium budget session coming up certainly as well. And I know that'll be a discussion there as well. So it's something we're continuing to watch, do what we can to get through the individuals on the list and get them access as quickly as we can. Encourage folks to look to see what other resources are available. To Cora's point, make sure that people are accessing their pathways, Medicaid services, if they're eligible for that. And I mean, that's what we're working toward right now.
Well, what I'm trying to do is kind of raise some awareness to the public that, I mean, whatever, however people vote, they vote, that's their choices. But we have a lot of need, and we're not able to meet. We're doing our best, but we can't meet the need because we don't have enough funding in the pot to do it. And that just needs to be said. And if people have issues, they need to contact their legislators because that's who does the budget. But I think people need to understand we have a problem because we have, I mean, this is a lot of people sitting there without knowing how they're going to get services or when. And I don't see this backlog going away anytime too soon. So we got a problem. That's all I'm saying, and we need to say so.
So, yeah, definitely. I think, yeah, systems errors, right? So, you briefly touched on the fact that, you know, I know we're a 2-year budget state, and you've said, I think you just indicated you're kind of starting to look at that budgeting process for the next 2 years, or did I misunderstand you?
I mean, we do start preparing around this time for the biennium budget, but I mean, certainly with the work we've been doing over the last several months with the Medicaid forecast and strategies and all of that.
And I truly don't mean this to be in a facetious manner. I do budgeting for our organization. I'm just curious, are we gonna have different people on that team? A $1 billion budgeting error is really a substantial budgeting error. And I get that the budget is like ginormous, and maybe for the state of Indiana, maybe $1 billion isn't ginormous, but when you do the federal match that we lost with that money, I mean, it's not, you know, again, you divide that out by the number of people we could have served by that shortfall in that number. I just want to make sure that we've got a good strategy, right? Again, it's about systems errors. How did we make that error? What was the system that caused that error? Let's make sure that system's fixed.
Yeah, so I want to address a couple things with that. It's been widely reported that this was a forecasting error. It's not like an accounting error. There was not money that was there and then wasn't, or was in the wrong bucket or anything like that. What the forecast situation, which was $1 billion, it was actually like $900 million over 3 separate state fiscal years, of where the April 2023 forecast did not appropriately account for the rapid growth in this waiver, in the aged and disabled waiver, which through this state fiscal year to date is at $2 billion. Last time this year, it was at $1 billion, 1.0 versus 2.0. It doubled. And I like to remind people that a billion is 1,000 millions, because if you're like me and you're not a finance person, it's hard to think, oh, a million versus a billion. I don't have $1 million in my bank account. I don't have $1 billion in my bank account either, but it's 1,000 million is how many that is. That is how significant the growth in this aged and disabled waiver, which is now the health and wellness and pathways waivers is. So to Dr. Burke's point, that shows there's a huge need out there, right? And there's some other things that happen with enrollment growth, utilization growth. And then of course we had significant rate increases because of provider capacity issues. With all of those things in mind, we have put into place a whole slew of new tools and transparency measures to ensure that the forecasting is more accurate, because that's really what it was, not an error. It was that it could have been more precise. And we could have had additional tools along the way that really monitored from a historical expenditure standpoint, what is happening, and then what does that mean for the future and what's coming down the pike. So we've instituted a policy change review committee where all of these different measures or policy changes, like having a wait list or allowing certain types of individuals to care for their loved ones, goes through a robust vetting process to ensure we have a strong understanding of the fiscal impact. We also have launched a new Medicaid financial transparency reporting page, and on a monthly basis, we're providing detailed programmatic expenditure, enrollment, and funding information, and that's out on our FSSA website. And I'm happy to add that to the minutes as well as with some of our other resources that we've talked about for the Pathways program. So all of these things together are going to ensure that we have the most accurate and robust forecasting process when we get to December, because that's really what ensures we have all the information that the policymakers and the appropriators in the legislature need to determine how much they're going to fund in Medicaid assistance for things like this particular waiver.
So, yeah, I mean, that's the budgeting process, right? It's all forecast. Like you could take a dart and throw it on the wall. I mean, that's the whole thing. So I'm happy to hear that you've put different measures in for your forecasting of the numbers of people that will need to be served. And, you know, I went back on YouTube and I watched your testimony regarding the budget, and kudos to you. That had to be the hottest seat.
Well, this is also coming up with it.
Yeah. Well, you know, and again, I am not saying this to you as a human being. I'm saying to you that as the person who runs a system, and the system seems to have some issues, right? And as the person who's the CEO of an organization, we never personalize errors that we find. We always know that they're system errors. Typically 99% of the time they're system errors. So finding that system that was flawed and fixing that system is critically important to making sure I don't repeat the same errors I had before. And so if this felt personal to you, I certainly apologize if I made it felt personal, because that's never my intention.
Oh, I appreciate that. And I certainly don't feel take it personally. I just want to ensure that the hardworking staff that works for me doesn't feel that they, that they are being.
And I just want to make sure that
here.
the system's been fixed, and it sounds like that you've done, that whole like Lean Six Sigma, let's take a look at this thing, let's find these issues, let's get that thing fixed, and let's make sure we don't have a repeat. So I do appreciate that.
Yep. Thank you very much.
Well,
Thanks.
thanks all for your service. And I want to say, out of our discussion this morning, as the Commission on Aging, taking a look at aging in the state, we have growing needs. And that needs to be said publicly. Voters will make decisions. This isn't going away. I'm at the top of the baby boomers. There's a lot of us. Our parents came home from World War II, got happy, and had a bunch of kids. So here we are. We've dealt with all of us before with the education system. The education system, I've said it before, had to put trailers around schools in order to have enough classrooms for us. We're gonna have to step up, the system is, or not. And I don't like what I see if we don't. But that's up to voters, and voters are gonna have to talk with their legislators, if they're gonna have to decide where we're gonna go with money. Our people here in administration can't print money. Well, that's been discussed in many ways, but they can't do that.
Hopefully,
We're gonna
yeah.
have to decide as a state, voters are gonna have to decide how we're gonna do this. We just got a lot of older people in Indiana, we're not the only state, we have issues with managed care, Medicaid Advantage, or Medicare Advantage plans all over the country. This isn't unique to Indiana, but we're gonna have to deal with what we've got. So it was a good, honest discussion this morning, and I think respectful of it. We'll look at it as that, but we all have to work together. This is a challenge, and it's a big challenge. But I'm saying in my community, I say to people, well, voters have to make a decision. I won't let people just blame government and go there and just, blame somebody else. What do we want? And we've got some folks that just don't have the money to take care of themselves. We're trying to support family caregivers. We've got a lot going on. The state's doing a lot better with that with some of our policies. So we're making some progress, but we have a lot of challenges. But I think we need to talk honestly about one another about what's going on. So anyway, wow. Leslie, it's your turn.
Well, we've covered part of what I was going to talk about anyway, so that's good. I will try not to take up too much time because I know we've got a couple other things on the agenda. I wanted to give a couple of updates. A couple of updates on the other things that Division of Aging is doing. So we've spent some time on pathways and on the wait list. Wanted to address a couple of other things as well. So wanted to provide an update on Adult Protective Services. So Adult Protective Services is administered by the Division of Aging. We are anticipating some transitions for Adult Protective Services in the next year or so. Historically, we have contracted with the prosecutors around the state to administer the Adult Protective Services program. They did notify us last year that they would not be renewing their contracts effective July 2025. So we've spent the last several months, and we'll be spending the next several months working on what a plan is for long-term sustainability of the Adult Protective Services program. We are working with Advancing States, who are a national leader in lots of issues related to aging individuals, but including Adult Protective Services. So they are coming alongside to help us with the evaluation and planning process here for Adult Protective Services. We did issue an RFI, or a request for information, in May to collect information from vendors that might be interested in facilitating and administering the Adult Protective Services program. We got a lot of really great information from that RFI. For those of you that know the state procurement processes, generally the next step for that is an RFP, or a request for proposal. So that's where we are right now, is sort of the planning and preparation steps for the next process for procurement, knowing that July 2025 is kind of the target date to make sure we've got a system in place to continue operations of Adult Protective Services. So we'll continue to share information as I can and as information is available. We are meeting next week, actually, with lots of stakeholders related to Adult Protective Services. So meeting with the prosecutors and APS directors, certainly meeting with AAAs. We'll be reaching out to other stakeholders as well in the coming weeks and months to make sure that we're getting a lot of good feedback as well on the system as it operates today, the challenges that we face with the way the system operates today, so that we are building that into our plan as well. Any questions on that?
Just an observation.
Yes.
So I know later I'm supposed to be talking about this emergency housing, which was very much surrounded around APS, which kind of explains why I haven't heard it, from them. I would just encourage you to kind of build in, since you're kind of have to redo it anyway, and we've got this new waiver program, that you kind of build that into the conversation of how can we have emergency housing services, because again, that's never going to go anywhere because of the waiver wait list. So, I just encourage you to look kind of downrange and fix that problem while you fix. God love you, I wouldn't want to cross and love him, man.
Well, and
Fix
so.
the baby.
He's fine, he comes along for the ride. But I am glad you brought that up. So I'll make sure that we circle back on that and on that emergency housing contract. I know there have been lots of discussions about it in recent weeks and months. That funding, that's ARPA funding that we're using for that emergency housing pilot with you all, and I think with Hooverwood as well. So we'll be in touch kind of to talk about updates with the funding and all of that as well too, because it's important. And I really want to see what we're able to accomplish with that to help inform some of this future work. Funding, as always, we've got to have money to do emergency housing, but I think getting that program in place with you all so we can collect some good data and information and really have something to inform any work that we're going to try and do in the future with that will be helpful.
Thank you.
Yes, thank you. Also wanted to give a quick update on the multi-sector plan on aging. So we had a kickoff meeting a couple of months ago with lots of folks from lots of different areas to talk about this 10-year strategic plan that we're putting together. We have established work groups, have designated some work group leads, and we have our first meeting for these work groups starting, I think, next week, if I'm correct. So lots of exciting work to come. We've got different focus areas that those work groups will be focusing on. Things like age-friendly economies, supporting different journeys to employment and volunteering, reducing barriers and access for folks on all kinds of different needs that they may have. I know I'm forgetting one, but different areas that we're going to focus on to make sure that, reframing aging. So reducing ageism in Indiana, but also thinking about intergenerational supports and connections that we can build as well. So those work groups are meeting starting next week. We'll meet several times over the next handful of months, and we'll help inform the strategic plan that we put together. Part of our goal is to come up with measurable objectives as part of that too, so that we can measure progress for that strategic plan over time. So it's not just a plan on paper, but something that we're working toward and can look at our progress. So I will continue to provide updates to the commission because I do think it's something that's really important for the future of the state and supporting older Hoosiers. I know lots of folks on the commission have been part of those discussions. Welcome any discussions with anybody that doesn't feel like they've been part of the discussion and want to be. We're trying to include folks from kind of all walks of life, especially certainly the health and human services and social services area, but also folks outside of those areas too, to make sure that it is truly multi-sector and thinking about kind of all different components around the state and different industries that should be involved. And then wanted to also provide an update on our dementia care specialist program. We, as part of the legislation that created that program, which is mainly an education and outreach program for persons living with dementia and their caregivers. So it places a dementia outreach specialist in each AAA around the state to help connect folks to available services. We, as part of that legislation, also received funding to have a statewide dementia care specialist program coordinator, and we have hired that person, and she started last week. So Kim Woods joined our team and is going to be coordinating that program and also making sure that program is integrated with kind of the broader dementia strategic work that we are doing in the state as well. So very excited for her to be on board. Hopefully lots more to come as she's getting up to speed and acclimated, but adding folks to the team to kind of help with some of this work too. So just wanted to share that update. And if anybody is working with us in any of that dementia space, you'll probably see her pop up, see her name pop up on things too. And then Dr. Burke, I know you had asked for an update regarding HIP and the HIP lawsuit. So we did share some information with you directly, but just acknowledging for the commission that we did issue information on our website. So for folks that haven't maybe been following along, there is a lawsuit that's been pending for actually several years regarding the Healthy Indiana Plan, challenging different components of the plan. That lawsuit was paused for several years during the public health emergency and the COVID pandemic, and then sort of restarted again once that public health emergency ended. There was a decision issued by the federal court in DC that voided approval for HIP because of some of the components in that approval that it found to be unlawful. And so We, as an agency, are evaluating that decision. We have requested a stay of that decision pending our ability to appeal it. Are working through kind of what this means for Hoosiers. Right now, HIP remains in place and people are continuing to get services under that. But certainly this lawsuit, causes some concerns with that. So continuing to monitor all of that. We do have information on our website about pausing cost sharing for HIP. That was part of the decision. So that remains in place as paused. So no cost sharing is occurring for HIP right now.
Leslie, this is Judy. Do we have anything planned for that? I mean, do you guys know what you're looking for?
For the HIP lawsuit?
Yes.
So we've requested a stay and we're planning to appeal that decision.
So right now, nothing changes for everybody?
Correct. The cost sharing remains paused, and then we have submitted a letter to CMS. That's also on our website. I can send that information around to the commission so you guys can review that.
That'd be great. Thank you.
Is there anything else that I can address? Anything we didn't talk about?
Yes, the contracts and the payment.
Yes, Aaron will give an update on that. Yes.
Oh,
So, yes, Dr. Burke had mentioned that she had heard concerns about the timeliness of our grants and contracts with the AAAs and then related delays in payments because of the delays in the contracts, and potential concerns with cash flow for the AAAs. So the contract life cycle and process within the state is very, very long and involves multiple processes and state staff and agencies, and many of the steps are outside of our control. And we've been working really hard internally to make some process improvements to try to make sure that we're doing everything possible within our piece to move everything through the process as quickly as possible. Within the last year or so, the state budget agency has launched a new grants management system called eCivis, which has caused some delays as we've worked through implementation and learning curves and trying to work through some bugs. There were some particular delays with the federal fiscal year 24 federal AAA grant agreements last year, which really caused some multiple months delays in being able to claim for those services. We don't anticipate those same delays with our federal contracts for federal fiscal year 20 or federal grant agreements for federal fiscal year 25. Our state fiscal year 25 AAA state grants, which those grants started July 1st, we have experienced delays with those as well, also related to eCivis. We've had to change the way that we handle the state match portion for our federal grants. We've worked through all of those issues and we anticipate that those agreements will be out for signature relatively soon. And the first claims against that grant aren't due until the end of next month. So we're still in an okay window with those. The AAA should see their ADRC contracts for signature next week. Are there any questions, or is that kind of where you were headed?
well, it
Is that-
sounded like slow was, we're talking real slow last year.
For the federal grant, yes,
Really
absolutely,
slow. And
very
really,
much so.
The concern was it really makes it difficult for some of the small organizations that are AAAs to,
Yes.
you have to pay your staff, you have to, you've got.
Pay your
expenses,
providers.
and We're not getting any of your claims paid.
Yes, yes. So yes, very much
So-
acknowledge that the
We
federal
all
for
keep
last year.
We'll keep adhere to that just because
Yes,
people can't function without money.
right.
And the
Yes.
AAAs took a hit because the Medicaid, I'm not in the weeds, so if I don't understand this, let me know. When they were doing the case management, that money came through for Medicaid pretty quickly. Now, that's gone, So now they're waiting for, their budgets have to be, well, primarily on some of these other contracts.
Mhm.
But if it's slow, they can't live on fumes, gas fumes.
Mhm.
So it's a problem. It's pretty serious, it sounds to me, that this just really needs some attention. So I haven't
Yeah.
really-
The reimbursement process is different for
Yeah.
the grants, so
But
we're,
they
we're
have
well
assumptions,
aware
so
and are.
Point is a system, but
Mhm.
that doesn't work very well.
Yes.
Anybody else, anything else? to
I have a question, Dr. Burke. This is Tarek. So I would just ask, I've looked through our OAA contracts and there appears to be some language in there around provided there is a statute that might provide a prepayment of sorts. So I guess my question is, if we're aware that contracts may be delayed, and I will admittedly say it's not at the division level, it's upstream. When I get a contract, I sign it immediately. Leslie or Andrew signs it right away, and then the waiting begins. And so the question becomes, are there other potential opportunities that may exist for the AAA network in those kinds of scenarios where we know we're not going to have contracts, I'll say, fully executed and subsequent claim workbooks for several months or 2 or 3 months after a funding period has started?
So it is. No, I can. So, and actually there is language in the Older Americans Act that speaks to, and uniform guidance that speaks to prepayment. We have had conversations with FSSA finance and administration to see how we might be able to change our processes to allow for that. We have run into a lot of roadblocks. So I guess if there's any ideas or advocacy that you think may help us move forward with that, I would encourage any feedback because we've just run into some roadblocks.
That's helpful, Erin. Thank you. The advocacy piece is what I was hoping to hear from you. Thank you.
Well, so the only thing I would add is we do have a state statute that does limit our ability to do advance payments. So there's, I'm sure, a lot of complicated interplay between what that means for a federal grant and what that means from a state level. But so some of those roadblocks may be legal roadblocks too. So, but I echo what Erin said. Always happy to take feedback and see what we can do to make the process smoother. I will say we're also looking to hopefully add some internal resources to help with claims processing and contracting so that we're making sure that at least on the Division of Aging side, we're moving things as quickly as we possibly can. But as Erin mentioned, we are one piece of a much larger process for both contracting and claims.
Yeah, and it's a major change that just happened here in Indiana with the AAA, so things that can be done to address this, and they have a very they have a legal role to fulfill also, but they can't do it without funding. It's complicated when it's federal and state, I'm sure, but that's, and you're the state unit on aging, so there we are. Okay, anything else on this matter?
You want to go into No Wrong Door while I'm up here?
Up to the Division of Aging.
Or were you done?
Yes,
You're seeing a lot of me today. So I am going to give an update on the work that we've been doing related to access to services and No Wrong Door. I've talked about this at a couple prior meetings. See if Joanna can pull up the slides. while she's doing that, I'll just start. And so as a reminder, No Wrong Door is the concept of an integrated, seamless, coordinated network designed to support individuals and their caregivers needing long-term care regardless of payer source. So we've talked a lot about Medicaid today and access to Medicaid services. No Wrong Door includes that, but it's really broader than that. It includes the whole payment spectrum, private pay, Medicaid, grant-funded programs, everything in between. And No Wrong Door involves information and referral, person-centered counseling, streamlined eligibility, as well as state governance. So we received a grant from the Federal Administration for Community Living for improving access to long-term services and supports for individuals and caregivers. It's a 2-year grant that started last September, and a key focus of the grant is the formation and support and development of a governance team, which is comprised of many folks from within FSSA as well as other state agencies and partners, including VA, IHCDA, and SHIP. So we have been working to kind of map out the system of access to long-term services and supports. And for the last several months, we've been really looking at any gaps and equities, barriers to work towards a plan for how we can work towards a No Wrong Door system in Indiana, and kind of build upon past No Wrong Door work that we've done over the past several years. So the governance teams come up with a vision, and I think I've shared this before, that we're working to sustain a No Wrong Door system of access to long-term services and supports. All Hoosiers and caregivers can easily obtain trusted information about public and private resources that support informed decision and access to LTSS options through a visible, coordinated system. So we have been working with UIndy on this project, as well as Health Management Associates and the governance team and other stakeholders. And so I'm going to turn it over to Maddie Shea with Health Management Associates, who's part of the team that has been helping us with this phase 2 of the project, to kind of talk about where we are with the implementation plan.
Thanks, Erin. Can people hear me?
Yes.
Okay, good. So we can go to the next slide, Joanna. So in phase 1, we learned that, through broad stakeholder input, that Hoosiers are really having trouble accessing information about long-term services and supports and resources across the board. We also learned that the system, it involves multiple agencies and funding streams that support people with disabling conditions. So it's really difficult for people to navigate all of these different, we're calling them doors, these different agencies with all of their different forms, and it's really confusing for the public. So the ideal system would give Hoosiers control, choice, and access to a full array of quality services. And this is not like, I know we just had a lot of this meeting was on pathways. This is for people who are low income and not low income. It's for people from when they're born until they die. There are people who need long-term services and supports. So that's really the vision for this, that would enable individuals and caregivers to have what they need to support their family needs. Next slide. So after a lot of discussion, very iterative interviews and talking with the No Wrong Door governance team members, we have a plan we are presenting to you now. So next slide. The first component of the plan is state governance and administration. So it's to refocus the governance on the implementation plan and goals, ensuring that each member of the governance team has a role and understands that. We're creating a charter, And the governance team will also continuously assess and improve the system, because we know that especially new things out of the gate, we'll have, plus it's a really dynamic environment. Things change, Indiana programs change, people's needs change. So this is going to be a process that will be continuously improved. Another component of governance and administration is ensuring that this is aligned with and embedded in the multi-sector plan on aging that we just heard about. Next slide. The second major goal area has to do with public outreach and coordination with key referral sources. So there will be a comprehensive communications plan to ensure that state program staff who are doors know not just about their own program, but about other programs that can help people who are calling. Same with partners, that they have this information as well as the community at large. So that, it doesn't matter if you have all the services in the world if people don't know about them. And those who are most disadvantaged are the ones most likely to not know about them. The second goal here is to implement robust training and education for community navigators and frontline staff. This would be ongoing so that they understand about these resources and services. And then the third is to promote awareness and understanding of the system and solicit this continuous feedback from consumers themselves as well as providers on the system so that it continuously can be improved. Next slide. Another component, I will say that these components come from the Administration on Community Living. This was funded, as you heard from Erin, with a grant from the Administration on Community Living. And these are areas that they are particularly focused on. So this goal is around person-centered counseling, and it's to develop and disseminate a training for state staff, as well as your MCEs, and people who frontline providers in the field who provide person-centered counseling to make sure they understand about all these resources for long-term services and supports. Next slide. And then one of the problems is nobody knows where to go for information. So a big goal area is to establish one source of truth for long-term services and supports information. That's why when there's updates, it all goes to one place that will then, of course, be disseminated through many, many other channels. So this first goal under this topic is to compile the comprehensive information on long-term services and support resources. And we're well underway on this one, including eligibility, benefits, when it's available, locations, contacts, and this is something that would be updated regularly. And then to analyze the options, select and establish a web-based platform to share the one source of truth, so that people in the community and providers and caregivers can all access the information. Next slide. So this, I don't know, Erin, if you want to hop on for a second and talk about the MPA alignment. Next slide.
Sure. So we have.
Oh, actually, I meant Aaron Tripp, but sure.
Good morning, everyone. There's actually a lot of this has been covered very well by comments from Leslie earlier and Maddie's point. The one thing to highlight here is both on the work underpinning the No Wrong Door and Age Forward Together, Indiana's multi-sector plan for aging. There's a lot of similarities in the fact that both of these are very future-facing initiatives. So this is really looking at how Indiana grows and develops these areas in the future. it's both critical that they're relying on a lot of community engagement. As Leslie pointed out, the work groups for the development of the MPA are kicking off next week. And there's a lot of excitement behind that process beginning. And also, we heard about new programs earlier in the day. Both of these are not looking to necessarily build new structures, new programs, new services, but really initiatives to try to organize and build upon what already exists. There is a lot of great things that are happening in Indiana for older adults and all of us aging across the lifespan. And these efforts are really to try to align those, bring them together, and make sure that they're working well for all Hoosiers. And there's just a little bit of additional detail on the 4 goals that Leslie had indicated earlier. But certainly there will be, I imagine, a fair bit of updates as the development goes on back with the commission as well. Maddie, back to you.
Thank you, Aaron. Next slide. So we wanted you to know that there will be continued engagement beyond the grant. The grant ends in August. But this was really just to get you started. So you should be hearing more. Next slide. So are there any questions or anything you want to talk about?
I will just add, this is Erin, that Erin Wright, we have really tried to approach this from a realistic, doable, manageable lens rather than kind of pie in the sky dreaming, so that we can continue to make those incremental steps towards truly having a no wrong door system, because there's, a lot going on, a lot of competing priorities, and we're just trying to be realistic with the time and resources. So
okay, thank you.
All right, thank you.
Anything else from the division page?
Thank you.
Thank you so much for your updates. Okay, our advisory committee reports, the Living Longer, Living Better Collaborative. Well, let me say I am now on the Reframing Aging work group for the multi-sector plan on aging, which really dovetails into the work we've done with trying to work with communities and helping them prepare for a growing older population that both makes many contributions to the community. There's a lot of grandparents raising grandchildren, older people volunteer, older people invest, other people. It's not all a drain, but we also know that we have older people who need services. So I am looking forward to participating in the Reframing Aging work group. And so I'll take some of our thinking about the Living Longer, Living Better Collaborative into that. We're trying to, yesterday I made some contacts with public libraries and get them involved in some of this. So we'll move forward with this. Okay, shared decision making, Judith.
We are working on, and this is something I wanted to get to Leslie, but I said it, guess it's the wrong person. We are working on getting CASAs put into the guardianship courts. And when it comes to doing the APS, I'd really like to see that be part of that program. So since you're re-looking at it, if you could look at that too, that'd be great.
Okay, thank you so much, Judith. Deb, emergency housing.
Well, I kind of gave a little bit of my update when Leslie was up there, so I think it might take a little bit different path than what I was thinking, but hopefully we can get something worked out, so.
That's not going away. She showed up in my community yesterday, so. And very much a person who's been seriously and persistently mentally ill for years, now no place to live. Local how can I say this? Local authorities really don't know what to do and we need us. So I said, call the hotline for NPS, and we know that's not perfect, but working on it. So that's there. So thank you for working on this. Kelly, are you on to talk about family caregiving? I know she's attending a meeting today in Florida, so she probably couldn't be. I'm on that advisory committee. We are meeting next week, continuing to look at some of the issues that are surfacing as we move forward here. So we are active. Dan, are you on this morning? Don't think so. Any hands? Dan's been working with some people focusing on housing with supports. And Dan is not here for the Senior Center Coalition. Kristen. Always look forward to what you have to say, Kristen.
Hello, everybody, and welcome to new members. I said hello to Steve, longtime colleague and friend, and he blamed me. So, so you're welcome. I4A and its advocacy desperately wanted your expertise on the board, as well as the Commission on Aging and the Choice Board members themselves, right? You requested mental health and things like that. So you are very welcome, as to all new members, right? Right, okay. So I want to start out in this time of transition to really kind of call out some of the, almost heroic efforts the AAAs have been making through this transition. There's been between the Medicaid strategies that came out on the LRI transition, the AND wait list, that started in February, to the change in direction related to AAA's roles in managed care, and the effects that had on agencies, to realigning level of care processes. It's been really a lot of significant work, and especially given impacts on agencies' staffing related to any needed changes, such as laying off staff or reassigning staff, as well as staff transition as MCEs kind of snap them up. It's really been kind of a trial by fire and managing through a lot of crisis. And I really want to recognize everything that AAAs have been doing with a real focus on ensuring that consumers are okay and really trying to fulfill and ensure people have what they need, as well as protecting their own agency sustainability and mission. These are nonprofit organizations that have a duty to protect their long-term mission. And a lot of the decisions they've had to make are towards that, even if it has meant some difficulties in the short term. So I really want to recognize all the staff's role, and just really, give them some encouragement when you have a chance to see them, and recognize they're trying to ensure these services, regardless of who the funding source is, can continue for the long term. So with that all being said, I want to share with you, and especially if you're new to the board, you may not realize that our AAA network in Indiana is recognized nationally. We have many effective AAAs that operate individually and as a network. And this was borne out in our national conference, which met just last week. And it was like the Indiana show. We had Connie Benton Wolf received the prestigious President's Award from US Aging for her leadership at Aging and In-Home Services. They also present Aging Innovations and Achievement Awards, and Aging and In-Home Services was recognized for the Community Care Hub of Indiana. We had lots of Indiana representatives that were selected to provide conference presentations. And, you know, this is a large network nationally. It's like 650 AAA strong and tribes. So there is kind of a National Caregiver of the Year or Care Manager of the Year award. And Richard Gado, I'm saying that wrong, and Tarek, maybe you can help me, received that award at Socoa.
Guido. Richard.
Guido. Yes, Richard Guido. So it really was kind of embarrassing, you know, like as the week went on, how much Indiana was being recognized. So I've included some of that information in your packet, and you know, and it's not only about the services they're providing in their community, it's about leadership we're providing to the network nationally. And we've done that as a state association too. So kind of along those lines, we also, Laura Hulsher from Generations was invited by Senator Braun to provide testimony at a U.S. Senate Special Committee on Aging hearing on Older Americans Act reauthorization. As an association, we've been working with Senator Braun's office. He is one of the team of 8 senators working on writing that language, since he's the ranking member of the Special Committee on Aging. And so we've been working closely with his office staff and on reauthorization priorities. And as a result of that, they asked us to identify some potential witnesses. And so after speaking with a number of AAA executives, they settled on Laura, not only because she's been in the network forever and is expert in rural AAA issues, but I'm sure the fact she covers Senator Braun's hometown might have something to do with that as well. So there is a little bit of a write-up on the success of her testimony, as well as another AAA colleague. But I also included a personal email, and all of a sudden I'm getting choked up. I don't know why, because I'm so proud. That came from the U.S. Aging Policy Director to Laura. And Laura didn't know I was going to share this. But it basically says, Laura, you know, based on this policy director's experience, who has been with the National Association for more than 20 years, that Laura provided some of the best witness testimony she's ever seen and handled herself most excellently with the on-the-fly questioning. So I just really want to call these things out because you're hearing a lot about crisis and transition, but it's really important to recognize how strong we are, and we're going to continue to be that way.
And that testimony is available if anybody wants to watch that. I did go back and watch that, and she really did an excellent job and represented Indiana very, very well.
Yeah. Yeah, and thanks to, you know, honestly, U.S. Aging worked and prepared her very well. So I want to highlight the U.S. Aging staff as well for their work with Laura. But yeah, she handled herself amazing, amazing. So, okay, so I'll stop tooting that horn and tell you a little bit more about what's happening nationally. Senator Braun has introduced some additional legislation on top of the Older Americans Act reauthorization in response to some of our priorities that we expressed with him. We'll see if that goes anywhere. You know, a lot of times in Congress, people file bills and they don't move. So, those separate bills align with some of our reauthorization priorities nationally. So I've included that in there for you. I also wanted to highlight, this is kind of another kudo for us, that a while ago, you may have heard us talking about the GUIDE model for dementia care. Medicare was coming out with a new fee-for-service model that included a lot of the things that we were doing with the ADPI, ABC Healthy Aging Brain Community grant. And so when that GUIDE model became available, AAAs reached out to their communities, and I believe that there were 7 or 8 GUIDE models approved for Indiana. And AAAs are involved in half of them. So, and hopefully there's at least half, and hopefully there's a few more opportunities for the ones we're approved that we maybe didn't know were happening. So again, we're really trying to be on the forefront of service delivery and innovation in all kinds of ways. Another thing that came out from the federal government, I'm going to switch a little bit now and talk a little bit more about federal policy, were similar to our states and multiple states doing multi-sector plans on aging. The government, national government, released a strategic framework for a national plan on aging. And so that framework, it's like a multi-sector plan, except for the federal government. And they are accepting public comment through September. And so there's an article in here, and I hope the article includes the information on how to provide comment, but you can always Google for that as well. Okay, let me scroll through that. Okay, that one's actually kind of long. Yeah, there's a pretty full description of it in your packet. I usually try not to have such long documents, but I thought that one was important. Oh boy, okay. Nationally, related to, we have some things going on with the federal budget, and the House released its proposed FY 2025 federal budget, which included Older Americans Act appropriations, suggested appropriations, and it was kind of a mixed bag for Older Americans Act. Some things went up, some things went down. This is just one budget proposal among, we're still waiting on the Senate and the president's. But the reality is we're most likely going to be under continuing resolutions through the election and into the first quarter of next year. So while this is just kind of an initial policy proposal and there are some advocacy requests around it, please keep in mind that it's probably not going to go anywhere for a while until after the election. Some of the other major things that really have a potential to impact the kinds of work that we do collectively, all of us, related to long-term services and supports are a couple Supreme Court decisions. And the first is what they're calling kind of the Chevron decision, which really impacts the ability of the federal government to promulgate regulations that go beyond what is determined to be the intent of any kind of federal legislation. And there's a significant, we've talked about all the final rules that have been released in the last half a year that affect aging. Our healthcare system as a whole relies on federal regulation being published. That's how Medicare rates get set. There's a physician's fee schedule that gets published. So depending on how advocates take this precedent and start to nibble at things they don't like, we're going to have to watch for that. It could potentially be really disruptive. And so there are some concerns about, well, what does that mean for this ongoing rulemaking that the federal government does? And that's just going to have to play out. So it's something that I want to just keep in your awareness because we may be commenting on it in the future. The other Supreme Court decision had to do with allowing allowing municipalities to continue to criminalize public sleeping. So basically, a homeless person can be arrested for sleeping in the open. If they don't have a shelter or a home, where are they supposed to sleep if they are not sheltered or whatever? And this is coming at it, and I'm not saying that Indiana municipalities have an issue with this. I haven't heard of any recent efforts that would result, but who knows what's going to happen now that this appears to be legal. US Aging included a commentary on this decision related to older adult homelessness. older adults are the fastest growing segment of our nation's homeless population. And in addition to that, we've talked a lot about housing insecurity across all populations. So I kind of included in your packet some, information about that decision, as well as just reminding people that we are dealing with a significant homeless problem nationally, and we're going to see more of that in Indiana related to the people that we serve. And our state legislature has really only addressed developers' issues, right? There's an article about how the money resulting from developer and city subsidies were made related to infrastructure that went through the legislature a couple years ago. And that was really a builder's bill as opposed to addressing needs for additional emergency housing assistance, addressing landlord tenant issues, et cetera. And so we just need to kind of continue plugging away at that if we're going to appropriately serve our folks. And I'm not downplaying the importance of that infrastructure money, but it certainly doesn't go far enough. And then the rest of the information in your packet, there were various kinds of, ACL published its profile of older Americans. United Healthcare focused its annual cost of care, which is interesting data, information on older adults in poverty from Kaiser Family Foundation, et cetera. And finally, a couple of miscellaneous articles towards the end addressed kind of the uptick in scams. And just a reminder that we are seeing a lot more continuing increase in scams, particularly targeting older adults. And reminding, kind of as a reminder too, that we as a state, through the Indiana Senior Medicare Patrol, which we administer, as well as other kinds of, AARP has prevention messaging and training, our Secretary of State's office, our Attorney General's office, Adult Protective Services, we all are trying to work together to prevent senior exploitation. So we'll see, this will be a good opportunity too related to financial exploitation to see how we can enhance the state's capacity in the new APS model, whatever that's going to be, to really address and prevent those kinds of issues. So I will stop there and see if you all have any questions.
I just have a comment.
Mm-hmm.
I don't know how appropriate it is, but I'm just thinking, several years ago when I worked in Philadelphia, we're in a big change here. We just did a lot of changes here in Indiana. Several years ago when I worked in Philadelphia, the hospitals decided, since they couldn't bill directly insurance companies for social workers, they would just get rid of them as a cost containment measure. Well, guess what happened? Things didn't go well. All the social programs started stacking up at the door of the administrators. And that wasn't working. Well, the problems didn't go away. It's just they didn't have anybody in the system to deal with the people who were having the problems. And the administrators were like, I don't know what to do with these people. So then they went back and tried to hire back the social workers. The only problem was they didn't come back. They wanted more pay when they came back and stuff. Well, in a cost containment strategy here in Indiana, we're an interesting state. We're a state that likes to do things locally and have local control and we say we appreciate people helping one another. We like nonprofits and so forth. But in our cost containment strategy, and I'm not judging, I'm just saying this happened, there was a choice to go with for-profit, managed care organizations as a cost containment to take care of this population. Well, we're in that change. I don't know, but my guess is there's still going to be a role for the nonprofit organizations, the AAAs. This is going to take care of everybody. The way we like to do things at a local level in Indiana, there's going to be people mighty upset having to talk to somebody at a commercial insurance company somewhere that won't know anything about where they live and who their neighbors are and what's in their communities. So there's still gonna be a role for the AAAs, but there'll need to be some funding for it. That's where we're gonna stretch and strain a little. But I don't know, as human beings, we go here and we go there, and then we have other problems that we think one thing corrected that it didn't. So I think we're in a time where there'll be some push and pull for a while. But thank you. The AAAs play a very important role in Indiana. They have in navigation. I don't know where all that's going to go. You already heard me carry on about, I don't think people know what's going on and where to go, and not blaming anybody, but they're just some things. We've got people that need extra help. And it costs some money, and then people don't want to pay for it, but you know, that's the human condition. But thank you very much. Anything else for Kristen besides my carrying on here? Okay, everyone. Wow, we've had quite a meeting today. Well, the state of Indiana will continue operating. We have people in the state of Indiana that will continue to need services, and we'll move forward and meet each day as it comes. Thank you very much, everyone. With that,